I hope you enjoy this discussion of modern retinal laser therapy. This discussion begins by placing modern retinal laser therapy in the context of a wider approach to treatment and prevention of the chronic progressive diseases of aging. This approach is what we call PATH, Pulsed Activated Thermal Hormesis. We will look at two particular cases of neurodegeneration that are extremely different, but both effectively addressed by modern retinal laser therapy to illustrate the approach. The first is age-related geographic atrophy. The second is open-angle glaucoma. These are my financial disclosures. There are two fundamental principles to modern retinal laser therapy. First is low-intensity treatment that's reliably sublethal to the retinal pigment epithelium. Secondly, high-density treatment, including confluent treatment of diseased retina in large areas to maximize the clinical effect. Inherent in the concept of modern retinal laser therapy is that laser-induced retinal damage of any kind is contraindicated as a complication of treatment, not a goal, because it results in the loss of visual function, risk of vision loss, it's pro-inflammatory, and reduces the effectiveness of treatment clinically. Therefore, modern retinal laser therapy does not include approaches that are inherently or unpredictably damaging. These include 2RT, SRT, the Pascal, and even micropulse laser performed at high duty cycles or with short wavelengths at excessive power levels. Modern retinal laser therapy is actually part of a larger approach to medical management. I call this PATH, or Pulse Activated Thermal Hormesis. Pulse applies to any electromagnetic radiation applied in pulses to allow precise control of induced cellular hyperthermia. This applies not to just the eye, but to any organ system and tissue in the body, which can be assessed in different ways, either by laser treatment, ultrasound, or radiofrequency, EMR. Activated refers to activation of heat shock proteins that stimulate therapeutic immunomodulation. This is common to all cell types and normalizes cell function whenever it occurs. Inflammation is reduced, and treatment is repeatable and infinitely renewable, which is a good attribute for treatment of chronic disease. PATH is a thermal mechanism, and thus it is not the same as photobiomodulation. Hormesis is an ancient concept in medicine whereby health is improved by stressing the system. The most common example is exercise. There are no adverse effects, and hormesis is sublethal. Because chronic diseases come on slowly and insidiously, they tend to evade our reparative mechanisms. PATH activates those mechanisms to address the degradations of chronic disease. In a normal cell, wear and tear result in protein unfolding that is addressed by the endoplasmic reticular unfolded protein response to maintain proteostasis and cell health. In chronic disease, an additional stressor such as diabetes or a genetic defect can, over time, lead to excessive protein unfolding and unhealth. Unchecked, the cell can be overwhelmed by the excess of unfolded proteins. The intracellular environment becomes hostile, reducing the half-life of proteins and enzymes within the cell from 90 minutes down to as low as 18 minutes. This leads to a vicious cycle of increased inflammation, debris, apoptosis, cell death, and organ failure. In the eye, vision loss. Modern retinal laser therapy interrupts this cycle by accelerating protein repair, restoring proteostasis, inhibiting apoptosis, and normalizing cell function. The principles of PATH contrast to that of targeted drug therapy, which postulates that an effect might be achieved by blocking a certain molecule or process. The thesis of PATH instead is what would be the effect of normalized function. Targeted drug therapy is necessarily difficult and highly unpredictable. The path approach is simpler and highly predictable, however. That is because it exploits a universal mechanism common to all cell types. It's important to remember that all chronic diseases are diseases of aging. This is because regardless of the stressor, these diseases progress with time. Because the retina is central nervous system, all chronic retinal diseases are neurodegenerations. MRT improves all the same way by being neuroenhancing, neuroprotective, and anatomically neuroregenerative, as I will show in a little while. It's useful to consider the wide range of diseases improved by modern retinal laser therapy. Despite the fact that they all have different phenotypes, different treatments, different causes, MRT improves them all, objectively by electrophysiology and by every visual function test used thus far. So today I'm going to discuss geographic atrophy and open-angle glaucoma as models for use of modern retinal laser therapy in retinal neurodegenerations. Targeted drug therapy for geographic atrophy has been all the rage of late. This hypothesizes that inflammation is a key driver of geographic atrophy, and by targeting specific inflammatory processes, the geographic atrophy can be slowed. It is interesting to consider that the target of this treatment is actually healthy tissue, not the unhealthy tissue. A problem with this hypothesis has been a study that showed that there was no relationship between complement factor genotype and GA type or progression. This suggests that modifying complement inhibition would probably be ineffective. This is a typical algorithmic depiction of the complement cascade, indicating the opportunities for targeted drug therapy intervention. However, biologic processes are not so simple. They are far more complex, as illustrated in this hyperlinking diagram. If you wanted to affect a change in the process reflected here, where would you target? This place or this one? This diagram actually depicts approximately 64,000 hyperlinks from references in a single book, not a living cell. The average cell, however, has 10 to the 680th links. It is impossible to manipulate any single one of these without affecting every other. This illustrates the difficulty of targeted drug therapy to do what one desires and not many other things that are undesirable. As a simple example, what one thing would you fix to get this car running? Because of this irreducible biologic complexity, targeted intracellular drug therapy rarely works. When it does, it's generally by accident. Unexpected side effects virtually always predominate, and these are virtually never therapeutic. The poor performance and high risk of the current complement fixation drugs for geographic atrophy illustrate this point. Modern retinal laser therapy and path, however, are non-targeted. They're agnostic to the cause of the dysfunction. They normalize cell function in all applications and decrease chronic inflammation that drives disease. For targeted drug therapy to work, everything has to be perfect. You have to have the right target, it has to be successfully targeted, and unexpected side effects have to be good or minimal. MRT, on the other hand, is anti-fragile. This is a process that performs better in imperfect conditions. A good example is a paperclip. It always works. So let's look at SDM, vision protection therapy for geographic atrophy. When you think about geographic atrophy, it's important to try to understand where the problem is. Is it within the atrophy or outside it? A good model for geographic atrophy are retinal laser lesions that expand over time. When they do expand, they often expand through normal retina. Therefore, the impetus for expansion is clearly within the geographic atrophy and not in the normal retina around it. Contrary to popular belief, geographic atrophy is not dead. We know this because it responds robustly to SDM by many measures. It is, however, highly dysfunctional, and this dysfunction within the geographic atrophy is a likely source of the chemical driver of geographic atrophy. Because SDM normalizes the function within the geographic atrophy, it reduces this drive and slows progression. 4 years ago, we reported a retrospective study of SDM for geographic atrophy. This study included 67 eyes of 49 patients, average age 84, treated every 3 to 4 months with SDM. They were followed over 2 years before treatment and over 2 years after treatment. After treatment, the progression rate was slowed significantly by nearly 50% per year. Interestingly, smaller lesions were slowed nearly twice that much. There were no neovascular conversions in treated patients. This is a box plot showing the results of treatment in all eyes, as well as eyes with larger and smaller lesions. Note that the smaller lesions grew faster before treatment, but were slowed the most after treatment. It's also interesting to note that there appeared to be a floor effect on lesion growth, suggesting an obligatory rate that may not be reduced by any type of treatment. I'm now going to review 3 studies that suggest that open-angle glaucoma is probably the next biggest new indication for retinal laser treatment, especially MRT. It's well known that most patients with glaucoma progress despite good pressure control. This is because eye pressure is only half the problem. Open-angle glaucoma is a retinopathy. We call this retinopathy the retinopathy of open-angle glaucoma, or ROGUE. This represents a retina-derived chronic neurohypotropism. We know this because of the SDM treatment response. Remember that SDM, as modern retinal laser therapy, has no effect on normal tissue. When we treat patients with glaucoma, however, everything improves. This indicates that there is something wrong with a normal appearing retina in patients with glaucoma. In 2018, we reported a series of patients with glaucoma and optic nerve cupping treated with SDM modern retinal laser therapy. Following treatment, visual acuity and mesopic visual function were significantly improved, as were the pattern electroretinogram and the visually evoked potential. Of note is that this is the first report of an improved visual evoked potential in any setting, laboratory or clinical. Here's an example of a patient's mesopic visual function testing before and after SDM treatment. These scatter graphs show the significant improvements in VEP amplitudes, PERG amplitudes, and mesopic visual function. These results reveal a fundamental retinal abnormality in patients with glaucoma that is responsive and reversible with SDM modern retinal laser therapy. The second study looked at the results of standardized automated perimetry following SDM in patients with open-angle glaucoma, as well as optic atrophy from previous AION or multiple sclerosis. This study included 3 groups of patients, some treated in both eyes on the same day, and others treated in one eye prior to repeat visual field testing. Only the eyes treated one eye at a time, using the fellow eyes as controls, were analyzed statistically. After SDM MRT treatment, both the mean deviations and mean sensitivities of treated eyes were very significantly improved. Interestingly, untreated fellow eyes improved as well, but not nearly as much. The treated eyes were improved significantly more than the untreated eyes. In addition, all eyes with optic atrophy from other causes, including AION or multiple sclerosis, were improved more than 2 decibels. All of the patients in this study had a long experience with visual field testing, and thus we do not think that the improvements in the fellow eyes were due to practice, period. We note that contralateral improvement is frequently seen following SDM treatment in testing with electrophysiology, dark adaptometry, and other testing as well. We suspect this may be due to systemic immunoactivation or efferent optic nerve communication. These scatter graphs show the improvements in mean sensitivity and mean deviation in the unilaterally treated eyes. This is a 10-2 of an eye with glaucoma showing improvement after SDM treatment. This is an octopus visual field in a patient with advanced nerve cupping due to glaucoma, showing progressive improvement in the visual field over a 9-month period following institution of vision protection therapy. This is visual loss due to optic atrophy and multiple sclerosis improved after SDM treatment. This is a patient with optic atrophy due to AION who for 8 years had had visual acuity of 20/80. SDM vision protection therapy was begun and the vision gradually improved from 20/80 to 20/32 and has been maintained at this level for the past 2 years. What about the holy grail of neuroscience? Can SDM MRT for glaucoma show evidence of neuroregeneration? Over many years treating patients with SDM for various retinal problems, I noted that nerve fiber layer thicknesses seem to improve. This wasn't supposed to happen, so a study was done to see if this was a regular occurrence or not. This retrospective study compared 2 groups of patients, one managed with IOP control alone and the second with the addition of vision protection therapy over time. We looked at the trends in OCT measured nerve fiber layer and GCC thicknesses produced by the OCT machines. Here's an example of a patient with open-angle glaucoma who has received vision protection therapy for a number of years, showing a gradual thickening of the nerve fiber layer over time, something that is not supposed to happen whether or not one has glaucoma. Demographically, these groups of patients were very similar with regard to pressures, age, etc. The results were fairly dramatic, however. Positive nerve fiber layer trends were noted in only 5% of controls, but over 2/3 of the VPT-treated patients. Ganglion cell trends improved in 8% of controls and 43% of VPT patients. The mean changes in nerve fiber layer trends were significantly negative in the conventional control patients, but actually positive overall in the vision protection treated patients. With regard to ganglion cell complex thicknesses, VPT patients continue to show negative trends, however far less than the conventionally managed controls. In these bar graphs, the blue lines indicate improvements which are significantly more prominent in the treated eyes as opposed to the worsening indicated by the red lines. Note that the average loss of ganglion cell layer in the VPT-treated group was far less than the conventionally managed group, and in the nerve fiber layer thickness measurements, the average was actually positive with thickening of the nerve fiber layer over time as opposed to significant loss of nerve fiber layer in the eyes conventionally managed. The simplest explanation for these objective OCT findings is neuroregeneration. It's the only one of the possibilities that could account for the functional improvements we've already described. There are a number of things that SDM MRT does that could account for neuroregeneration, including activation of stem cells, modulation of differentiation, and transformation of micro and macroglia. Retinal cells from the central nervous system are not supposed to regenerate. Peripheral nerve cells do, however. They have identical genetic information. Therefore, the limitation on regeneration resides in gene expression, which is an epigenetic phenomenon. We know from other effects of SDM that SDM modifies gene expression through epigenetics. In summary, we see that the responses to SDM treatment and geographic atrophy and open-angle glaucoma are path proofs of concept. SDM vision protection therapy as modern retinal laser treatment is the first to exploit HSP-initiated therapeutic immunoactivation to treat and prevent disease. An argument can be made that the path concept is the most useful, powerful, and effective tool ever in medicine. It is non-targeted and anti-fragile. The mechanism of action is universal and applies to any chronic disease, any organ. It's preventative and therapeutic, renewable, and maintainable over time. The results are robust. It is safe, simple, inexpensive, and works effectively as monotherapy or in combination with other treatments. Thank you for your time and attention.